welcome everyone to the second half. And I firstly just want to thank everyone because firstly thank the speakers and panelists, which I'm sure you all agree have been fantastic. But I also want to thank yourselves here and those online because these forums only work if there's engagement and people get involved and discuss. And so I just want to thank you all because I think you'll all agree it's been a really fruitful discussion and we have more to come. So that's great. So welcome everyone both here in the room with me and those online. And I do want to just remind everyone that those that are in the room, if you could put your phones on silent or switch them off. But otherwise, please continue to stay involved. Those online, please continue to put your questions in the chat. We are following it and including it as we go through. So I am really pleased that we had this session because it really relates to issues that have already been raised earlier today, and it's called Can the Status Neutral Approach Reduce Stigma? And again, we have some fantastic speakers, and our first speaker is already primed and here, Professor George Burns, who is a professor at the Hanover Medical School in Germany. So over to you. Thank you so much.
Thank you for that kind introduction. It's really a great pleasure for me to be here, although it was a short notice, but I really enjoyed also the first session, and I think there was a lot of things said already that I really agree to. Unfortunately, we have to agree to, and I will touch on some of them. I was asked to give a short introduction about this concept about status neutral approach, and to be honest, I had to go through a bit of a literature as well, a bit of an academic approach as well, because it was laid out in scientific literature to some degree during the last years. This is one of the papers that firstly described and summarized this concept, and it's something that as you can see on the left-hand side is also depicted in a graph, which I will come to in a second again. We start with something more linear and not circles, which we will end up, but with a linear thing which probably reflects a bit more my life as a physician and HIV specialist. And it starts with HIV testing, and then people may be diagnosed, and then we've got this linkage of care that we've been discussing the last years very often, and we set goals of 90, being treated, being efficiently treated, and so on. But the HIV testing here in this graph also has very important wording below, bar before the bars. The test system, the testing itself is a bar, but there's many bars before that. And this is what we've talked about before we had the reports, everything that is around stigma that prevents people of having a test, approaching or getting those also offered. So there is stigma and also prevention in offering these tests. But I think it's very important that there is the left-hand side, and that was kept on separate for many, many years. So we've talked about this before. This was crucial. There's two crucial things for this concept of status neutral approach. The one is the U equals U, and I agree fully. I see that every day when I try to explain this. Either you get asked, is that really true? I've heard about it. And others that you tell U equals U, they ask, what exactly does it mean? And then you go through all these conditions, situations like pregnancy and sexual transmission situations, and it becomes complicated again. But anyway, the second important concept that became true and scientifically supported and more becomes reality is that PrEP works. And not only the oral PrEP, you know, all the new concepts. And that's something very important because that changes the understanding and the efficiency, of course, of prevention and gives completely different options. Although all these concepts are complicated in itself, but they need services to provide it. So this is, I think, the idea then to develop the other side, the left-hand side. So if you've got an HIV negative test, you still should be supported and should have all the offers and options that one can take out of this information. And it's listed here So apparently you need to talk about the risk that you might have, make people aware that there is PrEP, link it to PrEP, prescribe PrEP, and retain on PrEP, if PrEP is the backbone of this sort of left-hand side direction. And this concept of status-neutral service takes it to another level, I would say. It puts, again, on the top, as you can see, the people and the test results. And then on the right-hand side, you see, either you've got a positive test result and are retained in care. And you remember probably on the right-hand side, we've got for many years different approaches and different efforts to get people on treatment and, of course, keep them on treatment. I'd like this to rephrase this sentence from that initial paper. Any test result supports action. So whatever it means, it is how you qualify to be tested that makes you a person that needs to be looked after and should seek the advice and the support from different services. So on the right-hand side, I said, we were, and we're still struggling to diagnose people early enough so that they really benefit from treatment. We lose patients off treatment, and there's been lots that has been developed over the last years to try to improve this and the treatment engagement and to have a quality of care and standards of care. We mentioned that before. We try, of course, to define and assure and also measure in different settings across Europe and the world. But there is also the left-hand side, and that is PrEP-driven mainly, but not sure whether PrEP is the exclusive requirement or goal in the end, but this is one that is mentioned, where people should be made aware of the option to receive PrEP, to discuss this by the prescriber, and to get people on PrEP and then keep them on PrEP. And you see, there's also one arrow going back because PrEP may fail. And that can go into the other part of the care if you've done, despite PrEP or other measures, infected with HIV. And we lose a lot of people on the left-hand side. I just put in one paper because I was one of the editors to handle this with a study from France to measure where are the gaps, where is lack of knowledge and lack of action to get people that are at risk, that they understand they're at risk to acquire HIV, where they are identified, supported, and get information about PrEP and are put on PrEP then in the end. Because also it's important to have quality assessment there as well, repetitive HIV testing, STI testing. PrEP is not drugs, it's a whole delivery of care as well. And we know that there is a close correlation. The better you take the pills, or the better these pills are delivered, if you want to, the better is the efficiency and the more we prevent not only infection but also probably resistance development, which we very often fear. The key point of this is that one tries to put the person first and not the disease. So you don't have to qualify with a positive test result in order to get care and support, but also being eligible sort of for an HIV test makes you a qualifying person to get into this system, either the one or the other way. And the structures that are required for this are, of course, very important to discuss. It's said that you need a lot of around this. I was just thinking about Sally and your case report. What sort of support and structure and infrastructure would you need to support her and then take out HIV? She doesn't have to have HIV for all the problems that you were describing, to make her the difficult patient and to see all that stigma that she's facing. And it requires, again, different partners, different funding, probably for proportions of it or for different services that you want to include. And I listed some of them, and many of them are very important, and they were mentioned. It comes from training, education, getting people back into work, dental care, lots of other things. And you need them on both sides, you know. It's those patients, we've got the difficult to treat patients, sort of, on both sides, that would need this support. and it goes down to transportation, to access to these services and the care. And it's said that this could be and should be really depending on the environment and the local circumstances, and whether it's London or another city or another place, should also be oriented clearly to what are the targeted population, what are the populations which are most in need and could probably best benefit from this. And there is a few suggestions here which I've taken from literature and the internet and some places where people start to establish this. I think one of the biggest questions, of course, is does this normalize anything? We were talking about normalization. I think we are all struggling. Is HIV something specific, or should it be part of infectious diseases? We are stigmatizing also other people in that, not everyone achieves a viral load below limit of detection. So if U equals U is a quality that you should achieve, what then about those that are not able to do this? And we are also keeping young doctors out of HIV medicine because we're making it very complicated or rather routine and boring. So sometimes I think we don't know really where to go. And the big question we should discuss later on, whether that is really helpful to destigmatize the whole situation and get this out, because we're still talking about people that are involved here. This could be all of us. We're not talking to those which the biggest stigma comes from, which is around. Also, that wording was nice, the sexual transmitted disease clinic into more culturally competent sexual health clinic. I think the wording somehow captures that, it's about the understanding and where you really want to go. What is probably an idea of reaching out to those that don't know much about HIV, it's also the idea that we need to change then the wording and get HIV into a different perspective. This is just some of the examples. Be HIV sure, PrEP, condoms, treatment as prevention, U equals U needs to be campaigned also in order to get the people first and not the test results as the decisive entry. I found that in the end quite a bit funny that this sentence was one of the key summaries of that initial paper, virtually eliminating HIV infections effectively, supporting all people with HIV, and there's something missing, and all without HIV, to lead to a long and healthy life and eliminating the disparities that persist among some of these populations. I think what's crucial is really, this sounds to me still like a concept, very convincing, very smart. I think it's the question of how can we incorporate this and what needs to be adapted or developed in order to make this really work. Form follows function, I said in the end. Does this have to be in one building? Does this have to be one service system, one-stop shop? Or how can we establish something like this, depending on the environment? And I'll leave it there, and I'm happy to take some questions. Otherwise, I think we're going to discuss this later on.
Thank you. Thank you so much. Thank you so much for setting the scene so well. And I think that we do have a couple of minutes for questions. So if there are any questions, please feel free. I'm feeling and hearing silence, but I just want to be sure.
Don't worry.
Okay, no, that's fine. No, because we have you for the rest of the afternoon, so I'm not worried about losing your expertise. So that would be great. So if I'd like you to take a seat. I can take a seat. Yeah, that'd be great. Thank you so much. And so now is my pleasure to introduce Alistair Hudson, and I'm giving brief bios because they are on the website, but just to give you an overview of Alistair. So Alistair is currently the CEO of HIV Scotland and the UK country coordinator for the People Living with HIV Stigma Survey, which is actually the UK's largest community-led research initiative looking into the lived experience of stigma and discrimination for people living with HIV. And Alistair is going to be talking to us about, is the status neutral approach affecting stigma? Thank you so much, Alistair.
Nearly fell down the back of the stage. A great way to start. So, hello everybody, and as the Glaswegian here, welcome to my hometown of Glasgow. It's a very beautiful city, and I've just returned here after 33 years in the London. It becomes the London whenever you leave, not London, it's the London. That's how we kind of stigmatise all things Londoners. Anyway, I guess I should present my credentials and my excuses. My name is Alistair Hudson. I'm 54 years old, and I am, I guess, a proud community member. I openly live with HIV, or rather HIV lives with me. I pay the mortgage. It doesn't get to play the piano, and it sure as hell does not get to cook in my kitchen. And I was diagnosed in 1998 in the London, at the Chelsea and Westminster Hospital, and I've received treatment there since, through several changes of medication and an incredibly supportive medical environment delivered by incredibly skilled and caring, and for all of the dramas in the NHS, and there are many, considered care. I think I've had a really, really, really lovely journey with my HIV. I mean, you wouldn't go shopping for it, let's be clear. But you know, I mean, as HIV treatment centres go, it's been a very, very nourishing and nurturing relationship. So, the brief that I was given is the status neutral approach affecting stigma, this was on Wednesday, to be clear. So it was a bit of a scramble of a kind of literature review light to kind of have a look at what we have. So, status neutral approaches. When I read the name, I'd never heard of it before, actually. I had a conversation last week with Gary Brough, another echo chamber such as this. And I was talking about it, and it was like we had a bit of a differing opinion. I said, that sounds really interesting, neutralising or normalising HIV. I think it's something that we're all keen to do. It's becoming part of, I don't know how many years in I am, but, it's something that I sleep with Gilead every night. I throw a pillow over my neck when I go to bed, and the side effects have been negligible. As my doctor said to me, if you're having side effects, you're on the wrong medication. And I think that's something that maybe needs to be spoken about more as well. Mm-hmm. Meds are very sophisticated, we know they work. My conversations as a punter, tablet swallowing punter, is about toxicity, bone density, any contraindication likelihood as I go through my HIV journey as somebody who is engaged with treatment ongoing. So I think, any agenda that's designed to reduce stigma is a welcome guest at our tables. I think universally we'd agree that. But I think systems-wide approaches come with challenges. So I think what I'd like to do is maybe just unpack what I've learned. Status-neutral approaches, even the name. So I'm going to start with this. Let me just get my glasses on, because your 50s do not come alone. One moment, caller. Right, so looking up neutral in my electric bell appliance, it says adjective, not supporting or helping other side in a conflict, disagreement, etc., impartial. Neutral, non-aligned European nations. You couldn't go there, could you, at this time? Number 2, having no strongly marked or positive characteristics or features, and then nouns, an impartial or unbiased state or person. Secondly, pale grey, cream or beige. I think a status-neutral approach in terms of a diagnosis, positive and negative are not neutral. They're two very, very different things. Just moving on. What have I found? So we had a bit of a literature review in the office. I've got an incredible staff team in HIV Scotland, and we kind of get into a bit of a, let's have a learning experience, and we chewed the rag about it. So this is what we found. Hold on a second. Let me just go back. Hold on. Let me see. I'm going to go to this first. This was the description of it. This is how it's described by the CDC. This is something that started in New York City when it was first kind of, I'm not going to read the slideshow because I find it quite tedious when people do. So I'm going to let that sit in there for a wee while just to read through, because a little bit more too. So read where you will and nod when you have. Okay. It's quite interesting the way it's described broadly. I think the City Department of Health and Mental Hygiene in itself was interesting to me. But moving on, this is the, hold on, let's just go back a bit. So, hold on, sorry. Let me see, these have all changed order, strangely. Right, here we go. What have I found? So we're there, right, it's the second part of it. We changed the order of these earlier, let's see. Second part of it is, they've all changed order. Sorry about this. Right, going from there to here. That's the visual to represent it, okay? So the idea, as I understand it, is you get a test and you're put into a pathway. If you have a reactive test, you're moved towards ARVs for treatments prevention. And if you don't, the intervention would be looking at prevention, PrEP, certainly for the HIV need, and considering other things like harm reduction or contra needs, or other STI stuff. We've got lots of system-wide options that have become remarkable in the UK context. Things like test and treat, treatments prevention, PrEP, enhanced testing should it be needed. So we've got quite a nice suite of structural interventions, I think, in the UK that certainly have led to significant reduction in incidence. In fact, these days, to acquire HIV, you have to be quite a high achiever, because for HIV to be transmitted, it has to be present. And increasingly, less and less, thankfully, it's not. So, interestingly, let me just see if this works in order. So, things that we found. So, let me just find the other slide, because these have all changed shape, which is quite bizarre. There were two examples of this. This being the first one. So this was an intervention for MSM in New York City. And the idea was to kind of change STD clinics into general sexual health clinics. And the outcome really was a 22% decrease in new diagnosis over 3 years. That's quite an achievement. And I think this model for the US is particularly interesting because it's an insurance-led model of care. And you know, the needs in America are very different to here. I think the UK system is considerably different. So there's another example I'm just going to give, which was particularly looking at trans. Hold on, this is very, very bizarre. Hold on. Let's see. And for transgender women of colour in the US. I think, you know, this idea of a systems-wide approach where you're looking at prevention for enhanced risk of HIV acquisition, which we know for trans women or trans men as well, is certainly an issue. So, I mean, certainly for populations that this is useful for, maybe people in harm reduction needs or people involved in chemsex, this might be an approach that would work. GBMSM, certainly. But for women and girls, is the need to go on to PrEP as potent as it would be here? You know, understanding what constitutes PrEP candidacy for women and girls. There's a lot of work to be done, I think, in the UK. I think, you know, I want PrEP, we want it now. It's great, it's achieved amazing things. In Scotland, I was at a meeting and we're talking about the PrEP success story in Scotland. At the moment, PrEP uptake in Scotland is 95% GBMSM. Of those 95%, 92% of them are white. That's a really effective intervention for GBMSM. But quite a range of our population are women and girls. And the work around PrEP candidacy for women and girls hasn't been as considerably considered as it could be. So I think that's quite interesting. In London, there's amazing work being done in the NHS, opt-out in A&E, Department Accident Emergency Departments. I think that's particularly interesting because during the last 4 months, I think, they've identified 102 HIV-positive persons. Of that 102, 60 of them were people that were diagnosed before and lost to service. Some of them would be late presenters, maybe some deaths, but I think of that 60 people, it'd be very interesting to know where that lives. I suspect some of it might be women and girls who maybe for a whole range of reasons, like maybe gender-based violence risk or risk of disclosing it within their family unit, might have been something that would have pushed them to deny it or for whatever reason. There's more work to be done in terms of those numbers. I think it's a really interesting time, and I think certainly things that are happening in HIV prevention around things like status-neutral approaches are really useful and valuable, but they have to be considered, I think, in a country context and a population context and in relation to access. I mean, I think what's happened during lockdown with COVID, a lot of things have changed shape in this country, how we're delivering HIV care. Some of it's online. Will the clinic as we knew it be the clinic of the future? I think there's things that are up for change, you know, e-health and online consultations, and then the advent of injectable drugs. You know, people are now going to be taking HIV treatment in different ways. That's got implications for stigma and disclosure and how we actually engage with the treatment as people living with HIV. So I think we're in a real change place at the moment, and that's exciting. That's got great potential and, of course, challenges. In the UK, HIV is a specialism. Many places clinician-led. Lessons learned from hepatitis, where it is a nurse-led service. I mean, a lot of medics, I think, are sweating blood. They're going to have to train as Band 6 in general medicine to go back into the field. So I think, you know, there's a lot of things that that are certainly worth watching as community members. But I think the thing that's interesting about fora like this is what can we do as community members, leaders, actors engaged in treatment, prevention and care that can inform and inspire system-wide or system-specific structures to inform and inspire better health-seeking behaviours, engagement with treatment and as such reduction in incidence. Because HIV isn't the big scary monster it was some time ago, thankfully, in our country. Other countries, goodness knows, it's very different. But I think there's an opportunity here for a big change piece. So I really welcome fora like this to have real discussions, and I really commend the chairs and the organisers for having meaningful, using JIPA language, but having meaningful engagement from community members, people like Rebecca and Luca, coming to share direct experience, because I think that's the gap that often happens. And because we are privileged, quote unquote, to sit in these echo chambers, which they are, it's meaningless unless we can turn some of the narrative that we have here into actions. It's all well and good planning. Action plans are great. The planning is the easy fun, but turning it into actions requires focus and commitment. So I think there's a real opportunity here. U equals U has given us great things. But as I said earlier, I think it's very easy for these things to reach glass ceilings unless there are actors driving them. I mean, certainly U equals U in a resourced healthcare setting is easy. And it's been amazing to see doctors really get behind it and our healthcare workers and third sector. I mean, just in terms of the stigma piece, a wee story. A couple of years ago, I was working in Ireland, in Belfast, and I'd been to this organisation many times, and there was a volunteer, an older man, lovely character, typical, like a Glasgow equivalent, but in Belfast. And we're talking about his diagnosis, and he had stopped working when he was diagnosed. And I said, so, do you know, fancy going back to work? He said, well, you know, I couldn't. You know, I mean, see, I was a chef. Oh, a chef, really? He said, you see, it's the knives. The knives. I mean, if I was to cut myself, you know, and I'd never forgive myself if I infected somebody. I said, what? He said, do you know that you're undetectable? Oh, I've been undetectable, but you know what that means. And we sat and we kind of unpicked it. I said, you know that if you're undetectable, it means that you're technically unable to infect somebody else. You don't have enough copies of blah, 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 to do blah, blah, blah. And you can see this wee man's energy change. You know, it was like suddenly to be the midwife for that change in somebody's consciousness, which I'm sure you've done many times. Many of us have in this room. And you see that thing happen when somebody goes, their world goes from being like that to being like that. Potential, you know, the potential for change and growth. This man had, for a million reasons in his own psychology, chosen to withdraw from life, the potential for employment, the potential for a fulfilling, happy relationship, and to engage. And this wee man suddenly thought, well, you know, let's get a go. I saw him later, and he was working in a wee cafe, and he was having a great time. The lassies he worked with were a laugh, and he was like, suddenly things change. I think, you know, these things that we've got, they seem small, but they've got the potential to make huge change. For New York City, this status-neutral approach might affect stigma. I don't know, I don't live in America. I think it would be very easy to kind of speculate. But certainly in the UK, the things that we have seen around U equals U and the potential for PrEP access has really been game changers. The change agents that we saw here were test and treat. If you get diagnosed, you get treatment, and you can be undetectable within 2 to 6 weeks. That's incredible. Before people start pressing buttons when they're most infectious, and you know, all kinds of things could happen. That in tandem with PrEP access, and then enhanced testing if you're in a higher risk population, have been game changers. And those are now structural in the UK, but they've been considered against the populations in question. More work to be done with women and girls, and trans people, and people of different populations within our narrative in the UK. And those conversations are now critical, because to get to what was described recently to me as the increasingly small needles within the increasingly small haystacks, we're going to have more targeted focus. But I think we've got the tools to do it, certainly in this country, and if we can inspire and inform in the same way we did with vertical transmission programme developments, I mean, that's been game-changing and hugely acknowledged as a success story globally. That learning can be applied to these smaller haystacks. Around the PrEP access stuff, I think we've done the first bit of it. The easy low-hanging fruit piece has been done. The next bit of it's going to be the challenging bit. But I think the combination of community, people that actually have got direct experience working closely with medics in fora like this is really encouraging. So I invite you to really engage and push yourself through the next bit of it and contribute. Because if not you, then who? Thank you.
Thank you so much, Alistair. And I'm mindful of time, so I really want us to get onto the panel discussion. But I know that I can see, I'm sure that some people just want to build on more on your reflections and experience with status-neutral approaches. So, as ever, we have fantastic colleagues to come on stage with us and expand the discussion. So first of all, I'm going to ask Rosalind Mbayo to come on stage, who is a community-based social work researcher and director at Africa Hurts, and has 23 years of work experience in the area of migration and health, and is based in Berlin in Germany. So thank you so much, Rosalind. And Rosalind, I just want to give you the opportunity to give your reflections, first of all. Thank you so much.
Yeah, thank you very much for having me here. And although it was on short notice, but I mean, having experience or doing the work for 23 years, I mean, I think I have a lot of experience or information to share. Talking about the topic we have at hand, that the status neutral approach, is it affecting stigma? It's a question, I mean, that I cannot say yes or no. For the work that we do in Germany, because like, if you talk about, I mean, we have prevention, we have treatment and care. So you start with the prevention part. We do testing, but before the testing, we had to do a lot of work. We wanted to work with role models, key players in the community. We worked with African pastors, the churches, because as head of their house, if you get to talk to the head of a house or home, then you have access to the members as well. So we did training with them. I mean, we have to tell them what it means, because in the beginning, they were very much afraid. They didn't want to hear about HIV and AIDS. But having talking to them, we did the workshops in different German cities or states. And over time, they allowed us to go into their churches to, have role plays and trying to sensitize the communities was very important to build trust, because you have to build trust. There is a lot of fear. When we talk about stigma, we shouldn't forget about fear. People are afraid. And doing testing, people, are afraid, because if I do the test and it's reactive, what happens? Germany is quite different from other countries. Access to treatment or access to health care is depending on the type of visa you have. So if you don't have the right staying permit, then you don't have access. So that's how complicated it is. So we also have the language barriers, structural barriers, institutional barriers. All these barriers put in place makes it very, very hard. So what have we been trying to do? Apart from talking to the African pastors, trying to engage them, we also try to reach people in their safe space. It's very important that you meet people in their safe space, in their settings, and go to them, meet them, and you're able to answer their questions. Been doing some of the tests. Some people say, I don't want to do a test. What I don't know doesn't kill me. So, and also that I cannot just go to the prison and tell the officers there they should lock me up. So they don't want to do a test because of fear. So we have to break down the taboos. And I think it's not only within the African communities or the marginalized communities. It's a topic of the whole nation. There should be a lot of awareness raising, because a lot of people still don't know about HIV and AIDS, and HIV and AIDS is just within closed doors. And the awareness, of HIV desensitization should be something that should be for everybody. So it's not just for the marginalized groups. And of course, when you talk about African communities, they're a community within a community, and they are really disproportionately affected. And that is why we're trying to have peer-to-peer approach, trying to reach out to the communities through campaigns, educating them. That's the first step. When that is not done, the second step doesn't hold. And also, it's very important that for breaking stigma, all the stakeholders have to be involved. It has to be a participatory approach with affected people, infected people, service providers, everybody coming on the table, putting them in strategies. And also it's very important to first of all analyze what has been working and what has not worked, why hasn't it worked, and try to bring up new, innovative ideas. Thank you.
Thank you so much, Rosalind. I've already got some questions I want to ask you, but we'll move on to our next panellist. So our next panellist is Gary Brough, who is works with Positively UK, which is an organisation within the UK, and he coordinates their national HIV peer mentoring training programme, Project 100, and developed its HIV treatment literacy qualification. And he actually stepped up as joint interim CEO from 2018 to 19, and is now the lead for peer learning, partnerships and policy, and managing the Fast Track Cities peer support integration and empowerment program. So great to have you here, Gary, and just look forward to hearing your perspective on this topic.
Thanks, Vanessa, and thanks to the people who've already spoken for some additional thoughts in relation to what I had initially to speak about. And I think that the thing that's interesting for me, and the thing that I first thought of when I heard about the status neutral approach, was that it was a semantic exercise, and that whilst we've already talked about the importance of language and sensitivity to language, and that has the potential to change and challenge stigma, that a neutral approach to HIV status does not change my experience as a gay man living with HIV for 30 odd years. And therefore, we can change the language and we can change the services to make those services neutral, but we can't change society to make them neutral towards HIV. And so that was my initial challenge with it. Then with looking at things more, what it comes back to is that the idea that it is a whole person care approach, which is something I'm very, very much behind. And the fact that what this approach does is consider equality and equity in relation to that approach. So currently, I advocate for peer support within HIV clinics because I recognize that when somebody gets a diagnosis of HIV, the isolation, the challenge, the additional stigma that is layered upon their pre-existing life challenges that may relate to their gender identity, ethnicity, migration status, sexuality, class, all of those things are already something that has made them vulnerable to HIV probably. And therefore, HIV on top of that is going to magnify, layer, or exacerbate that. And so thinking about how important that is, I then have to think, so what about those people who are vulnerable to HIV, who come in for the test, get a negative test, and then just sent home? If you don't have something that then supports them to live well, you're doing what we do very much in the UK, which is to have a national ill health service, not a national health service. So if we don't focus on prevention, if we don't focus on community engagement and integration, and in making people feel like they're a valuable person in and of themselves and a part of a wider community and society which cares about them, then we're failing those patients, those people. And so for me, the idea that this approach could provide an addition to the currently, in my experiences, excellent HIV care, to think about the sexual health and to move that from that model of sexually transmitted disease to sexual health, then that's a really good shift to make. Mm-hmm. And so the other thing that came up within that is this idea that it needs to be designed and delivered by communities. And I think the important part of that connection, that community connection, when it comes to HIV, most of us have contracted HIV because of a desire to be close to somebody sexually, and to be intimate, and to be more intimate than condoms provides, for example, as just one example. And so if this need for a connection is there, how do we then think about services that engage people in better human connections? And so it's a wider societal piece of work that starts in schools with sex and relationship educations so that people have a better understanding of their health, well-being and their place in society. But it needs to then address the challenges that we see around sexual ill health. The main problem with that then is the funding and the ability. The fight that I've been having for the last 20 years just to provide peer support in an HIV service, let alone to think how we might do that in a sexual health and testing service, in an era where we are moving to home testing, kits being sent out, you send them back, you get a result, and then you come into the clinic if you're positive, because face-to-face services cost more money, is our great challenge. And so we don't currently live in a society where the government values health in the way that it should, in my opinion. Not my organisation's opinion necessarily, although I think probably most of my colleagues would agree with me. And I'm cautious about being political, but HIV, sexual health and health are political issues. And so until we have a greater value of health and well-being, we're never going to get to any kind of neutrality. So I support the concept, I support the potential to implement it, but I think for a semantic point of view, whole person care fits more comfortably with me.
Thank you so much, Gary. Great. And last but not least, we have Eli Fitzgerald. Eli is a trans man living with HIV, and he works with organisations such as Chiva and Positively UK. And Eli's Chiva's youth advocacy worker and youth project coordinator at Positively UK. So we're thankful that you're here, Eli. So look forward to hearing from you.
Okay. Shall I?
Yes,
yeah.
please do.
So, firstly, like Gary and Alistair, this was a new concept to me. Never heard of it before. And I still find it quite a challenging concept to understand, specifically as a young person, in which the sort of care pathway isn't necessarily the same. For a lot of young people, especially those born with HIV, there isn't that sort of, you know, you get tested and find out, you often just know. And that's your life. And then you're told that you have HIV. And that's sort of how that works out around that. And this is where I sort of find this concept confusing, in the sense of, does this sort of, how would this work away from this sort of sexual health clinic? And that sort of, how does it work in pediatrics, for example? Because if you're testing someone who is 16 or under and they come out negative, how do you then provide them follow-up support? Because there isn't necessarily that system in place to provide that support. And I also want to sort of mention on that, on the regional disparities that affect this, is that I have grown up in a rural-ish area. I mean, it's a small town, and it's in Wiltshire. And Wiltshire has no sexual health services, no support services. There is nothing there. It's one of the biggest counties in the UK. And if there is nothing there, how can we even provide this status-neutral approach? Because you can get tested, but you don't get support. If you get tested, you can test positive, there's no support. You test negative, there's no support. GPs, local practitioners, any healthcare provider probably doesn't even know what PrEP is, and that's the harsh reality. And I think when we sort of, there was that bar chart sort of that was presented earlier, and I was looking at that middle bar and I was like, okay, yeah, testing, but when you get tested, and I think there's something around this which always shocks me, and it's never really mentioned, is the discrimination you can face upon testing. And as a trans person, I've heard multiple times of people who, trans people, especially trans men, who access testing and are then told that you're a trans man, you don't need PrEP, or you don't need PEP. And then they go on and test positive for HIV. And I think there's something to be said around that discrimination within testing services and the discrimination that follows, because you can't for most services, we'll say most, it's very lovely. And I think, we've got amazing services like Dean Street and other LGBTQ+ inclusive places. But if you're testing in the middle of nowhere, someone who's never heard of or treats trans people like they're some random new thing that's come out of nowhere and they've got absolutely no idea what like transitioning even involves. And then also you're young and you're perceived not to be at risk, which isn't necessarily true. You sort of are placed in this in-between where you feel like you can't access these services because they are not designed for you. And I think I agree with Gary when he speaks about this whole person-centered approach, is that that's vital, but that's so specific to cities and big cities. And even then, they're terrifying. And as a trans person, I feel lucky that I have HIV because I can just ask my clinician to do my sexual health testing, because I would not go to a sexual health clinic as a trans person because I'm scared I'll be turned away. I'm scared I'll be treated wrong. And that's not acceptable, and that's not okay. And I think we can have status neutral approaches and we can have all of these systems in place, but that doesn't remove the boundaries allowing people to actually access these services in the first place. And especially those who are terrified of them or don't even, HIV, as a young person, if I look at that more broadly, my friends who don't know I'm living with HIV, they don't talk about HIV. HIV doesn't exist. It doesn't affect us because we're just living our lives, and it's not spoken about. And I think something that shocked me recently was I work with Chiva and their youth committee, and someone asked the youth committee a question about it's a sin and what they thought of it. And bear in mind, everyone on the youth committee is living with HIV, and there are all young people living with HIV, and all of them, I think it was all of them, hadn't even known that this show existed. It meant nothing to them. And I think we often view HIV and young people through this lens of, oh, they're consuming all this media, they love this. The media that most young people are consuming doesn't mention HIV. The world, for most of us, doesn't mention HIV, and we are in an echo chamber, and we've heard that many times today. And I think if we take ourselves outside of this, HIV is not talked about at all. So why would people who don't talk about it or even acknowledge it, why would they get tested? And I think that's something around that middle ground that we need to really look at a bit deeply. I'll stop there.
Again, I want to thank all the panelists and speakers because I think it's, first of all, it's just great to hear all the different perspectives, and already we've just had such rich reflections about it. And so I'm going to hand it over to the audience here and those online. Please keep sending through your comments and questions, but please, if anyone's got any questions they'd like to ask. Got one at the back there.
Thank you. My name is Dennis Anyango. I just wanted to sort of, maybe to all panelists really, the issue around when we talk about discrimination, we talk about negative experiences in primary care. I think fundamentally it's also about how willing the clinicians are to take interest in somebody's situation or particular circumstances. And we've had often conversations around shared decision making, and how it is important to ensure that patients are involved, that we have patient-centered care, and patients are involved in decisions about their treatment, including treatment choices and managing HIV. My question is, especially to the clinical panel, the panels who are clinicians, whether this is really in practice achievable, given the challenges around time restrictions and the rare occasions when you see patients. Do you think that there is a meaningful, a realistic chance that you can actually have a positive conversation with the patients or engage with them to a level that they do not feel that they are not being listened to?
Thank you so much. I might hand that over to Professor Byrne first.
You're asking the right questions, right? Is it realistically possible? You know, most infrastructure in healthcare, you would say HIV is easy to treat, things should be easier, it should be simpler, people go back to work, their life expectancies, this is what politicians see and what, people think. In reality, and that's what the prevention part brings in, people have lots of things that are challenging and put them at risk for HIV, and we don't have the resources for it. And the best thing you can have is that HIV specialists or clinics at least know where to refer people to or have close contacts to get things at least started, and start with some of the issues, unemployment, health insurance, and other things to support. But that's what I fear, and I agree to what you said. If you put this on a paper like this, outline and this very nice graph, if you think how much is needed to support this, it can only be justified if you've got lots of people going through all these circles. And this is why I think this is established in New York or explored and tried. And there also the campaign to go out and use other words like PrEP and we play safe and so on is probably useful. For many other places, as you mentioned, rural areas, you would say this is academic, very nice concept, absolutely in favor, but how do you do this, right? And that's still challenging. We see that now with, it's unfortunate, but it's with the refugee crisis that we need these resources again. It helps us at times to re-establish it, but I fear it will collapse again as soon as things get a bit better, or we don't have funding for it anymore.
Mm-hmm. Thank you so much. Any other reflections from the panel?
I think in relation to this, there is that, and it does come then back to funding and the resource for services that tend to be then specifically for already marginalized populations. So that's the additional challenge that we have. It's not HIV stigma necessarily. It's homophobia, transphobia, misogyny, discrimination against migrant communities, all of the issues that we have real problems with in society, and that despite the fact that we seem to be going through, a whole range of kind of progressions in relation to availability of treatment and becoming, better at managing conditions, we seem to be worse at interacting with people as human beings. Certainly in the UK, I think we're going in the wrong direction, not in the right direction. And I see that, echoed across Europe in relation to a lot of the political changes that are happening. And so until we think about those societal change, that we're going to be in a position where that's just not going to change. It goes back to the same point that Luca made earlier about sex work and the marginalization, the fact that those voices are not heard. And so I think for me, I kind of wanted to ask the panel at that point, so if what we need here is structural change and a different society, how are you going to do that? And then I thought, I can't ask her, that's a really mean question to ask. But I thought, well, actually, it's a question that I'd answer, is that, will I stand up and I be counted? And I think that's one of the things that this is looking at, and it's saying, that every person that comes in to seek a test needs to be valued and be seen as being important and have their needs met. But the other problem with that is, as Eli said, there are a whole bunch of people, and certainly in countries where we're already at the 95% diagnosed, that last 5% are not going to be the people that think they're at risk of HIV. And that's where we have that challenges then in relation to how you get that information out and how you make services friendly and accessible enough to have them engage with it, because those people are not hard to reach. The services are just invisible or hard to access. And so that then it becomes the challenge for us. But I think visibility clearly is one of the things that we can do as a community to try and raise awareness and engage people more effectively.
Thank you so much. I'm mindful to go on to another question, but I can't help but say, about distributive justice when it comes to funding. We really need to send to the most marginalised and have that follow in our funding. And I saw someone else's hand go up. Great.
Thank you. Ian Muchmore, I guess I'd call myself an HIV advocate. and hopefully following through on that. What I heard was that this concept is, there's a bit of rhetoric in here, it's a nice idea, the concern is it's a bit beige, and does it really lead to the stigma change that we really want? So back to the experts on the panel. I know we want to change the world, we're all doing HIV advocacy, but I'm interested, have you got a burning, actionable idea that will especially take us out of, I'll be honest, the obsession that we have around HIV and dealing with it in the UK within sexual health services? We're afraid, clearly, to go outside that model. I've lived in Australia for 20 of the last 21 years, and I've seen other models. But in the UK, it's all through sexual health services, and I feel that is exclusionary, and that's not going to meet the stigma things that we want to do. So have you got one thing that we could get behind, anyone on the panel, that would be, from an advocacy point of view, would begin to make that change, begin to break the system that we've got at the moment, so there is less stigma in the system? Any ideas?
Maybe if I can just answer that. I think there's lots of things that are on the table. I agree with Gary. I mean, I think sort of e-health and kind of postal services are really challenging. But the bottom line is, the buildings that we have, even if we did have 20 new staff going into a sexual health clinic, you don't have the rooms. The capacity issues within these services are at breaking point. I think really what's happened with monkeypox has really evidenced the vulnerabilities that we have within them. I mean, you know, I had a call at HIV Scotland, somebody was asking me about a TikTok video to remove a contraceptive device because she was keen to start a pregnancy journey. I mean, and I'm kind of going, you know, I know about these videos, I've actually seen them, they're kind of quite horrific, but starting your pregnancy journey with a trauma is not the best way to go. I think things that we have in Scotland, we've got HIV Scotland are running the first national postal home sampling service. And it's new, it's groundbreaking, there's things that we could do better, things we're learning from. But I think things like e-health and how we're engaging, I mean, that service, the uptake is 41% women and girls, and it's 54% heterosexual people that engage. So I think how we're going to use postal services and other mechanisms, it's a new science, it's a new space for certainly testing and access and the wraparound stuff in terms of prevention and pathways into other things that are required are being identified and established as we go, because we're some ways building the ships as we're sailing them. But there's no option at the moment because services, quite frankly, just do not have enough rooms and enough bodies to get people through the way that we need to. And co-production certainly is a very, very important thing, but it's a very expensive thing to do properly. So there's a whole system thing that needs to be considered about how we actually deliver these services, co-produce them with community, and really assess and engage with the needs that are required.
And Gary, I'll give you the last comment.
Thanks, Alistair, and thanks for the question. So I'm the community rep on London's Fast Track Cities initiative, and as Vanessa mentioned earlier, the three work streams around addressing stigma, to work with people living with HIV who are experiencing stigma internally, and to be able to support them to feel more comfortable with their diagnosis, more comfortable to live well with HIV, and potentially, should they choose, to be able to talk to other people about their status. That for me is the first part of it, because you have to start with people living with HIV, and you know, so it's an inside job. But then once you do that, the other part of that then is, okay, so how do we make services and the support that people access HIV friendly? And so the charter mark and the inclusion and training of HIV ambassadors to be able to speak more publicly about this. Society changes only when they understand the issues better, and we understand that as humans by hearing other humans. And so public awareness through lived experience for me is the important thing. And so when you take that from the places and into society, hopefully that changes. I remember a time 20 years ago where people whispered the word cancer because it wasn't acceptable to talk about cancer. And as a community, we have the ability to change that perception of HIV. And so to steal Terence Higgins Trust's campaigning phrase around "it starts with me," I take responsibility for that. I don't expect that anybody else should have to. And I heard the issue for the woman in Amsterdam there in relation to not everyone can or wants to or should have to stand up and speak about that if they don't want to. But if we can, those of us who can and will and are willing to do that, we have the potential to make it a better world for those people, if should they ever want to choose to do it. And so for me, it always ends up coming back to the personal, and that's where the action is for me within this. And that's why I want to work with the systems that are in existence to improve those and to integrate that support within them.
Thank you.
That's
so
my
much.
answer.
We have one more question, and I just want to acknowledge those online, because we're getting fantastic interaction where people are reflecting about different scenarios. So a lady in Africa, in Tanzania, was saying that she feels that we need more education and knowledge about PrEP amongst health workers, and people are talking about this strategy, but in countries where people at risk of HIV cannot come out openly about their sexuality. So lots of discussions, and thank you to those online.
Thank you so much. My name is Tinashe Grateful Forwardzo from the Global Network of Young People Living with HIV, also known as Y+ Global. I'd like to learn from the panelists on how are they involving young people to lead and inform some of the interventions that you have also mentioned. In our work, we have also realized that young people, they are not a homogeneous group. We also have young people who are in correctional centers or in rehabilitation. We have young people who are living with HIV and who also have a number of impairments. They might be having disabilities. We also have young people who identify as LGBTQ+. But they also identify as young people who sell sex. So I'd just like to learn on how are you involving young people in designing the interventions that you have shared, and how are they also at the forefront of leading those interventions? Thank you.
Okay, I will talk about the German experience. We have, in our test projects, we have young, people from different countries, because we want to make sure that we have, there's access to different groups, and we involve them. For example, when we want to come up with information materials, we sit with them, because as young people, they know how to reach, their peer groups, so we engage them, and they are part of, the development in our projects. They talk to their people. They have this WhatsApp and the social media. They engage with that, and they have their groups. So that's how we've been working with them.
Last word, Eli.
So there's many ways of involving young people in the work that I've done, in the work that we do at the Positively UK Youth Project, and also at the Children's HIV Association. And I thoroughly believe in that there is nothing about us without us, and that concept of, if you are having something that is for young people, that should be run by young people, in a sense of how peer mentoring works. I think one of the amazing things, I'll speak firstly about Chiva and what happens there. I think firstly, one of the amazing things about Chiva is that they've got their youth committee, and their youth committee I think it's about 20 young people all living with HIV between the ages of about 15 to maybe 18. And they meet up regularly. They are they're amazing. I'm just going to say that. And, but in a lot of policies and talks and attending international conferences and ensuring that they have a voice, I think that's an absolutely vital thing, an amazing thing that they have done for years now. And I remember myself at one point, I was on that committee, and it helped me grow as a person, but also understand HIV. And I think there's something about the importance of giving young people a voice, despite the stigma, despite the fear, and also allowing them to explore that, but also have a say in how their care works. And they've done this amazing thing at the moment of HIV in schools and education and policy around that. And Chiva have some amazing guidelines for teachers to understand how those living with HIV who are in schools should be treated, and also a toolkit workshop program, so that during sexual health, which when I asked sexual health and not sexual, I meant sex education, and how that works in schools currently. So I emailed them and I asked, is HIV an actual talking point? And unfortunately they got back to me and said, well, it's up to the teacher to discuss this, but it is in the program. And I think that's unacceptable. So I think it's amazing that, these young people have seen an issue, They fought for a solution, and now that throughout many schools across the UK, and I recently did a talk in a school, we're talking about HIV in schools, because that's where everything, that's the starting step of sort of young people's lives, and that's also where stigma is what I feel is most prevalent at some points. And I remember being at school and being told that the local river has AIDS in it, and then purposefully going for a swim just to make that a true fact. And I think, okay, maybe not AIDS, but yeah. But I think, you know, having young people involved in that such policy, the guidelines, the asking them and having them at the table, because so often we don't have a seat at the table. And so often I feel like I'm the youngest person in the room, and that's ridiculous. That's not okay. And young people are also often sort of accused of not having the expertise that they do because they're young. But actually, for a lot of young people living with HIV, they could, in some cases, be the person in the room who's been living with HIV the longest. And to then assume that just because they're young, they have a lack in expertise and a lack in experience is unacceptable. So to reassure young people that actually you do have these expertise. And then in my work at Positively UK with the Youth Project, we talk to our young adults and we ask them what they would like from us, because it's about them. Our service is for them, and to ensure that they have a service that caters to their needs. We go into clinics and we just ensure that sort of everything that we do is for them, but also from us, so we can relate to their experiences. Because, you know, so often in my life, I've had people double my age, not understand at all, try and tell me that, oh, I get it, I've been there. No, you haven't. You haven't been there. And that's just the reality. And I think I thoroughly believe that having young people, giving them a voice, having them a seat at the table, and just listening. We all need to listen, because that is how we make change. And so often I hear, young people are the future. The future is young people. But we're not paid to talk about our experiences. When we talk about our experiences, we're often talking about our trauma, and just the expectation that, oh yeah, they're young, they can talk about it, it's fine, we don't need to pay them, it's no big deal for them. And also just understanding that as young people is not one category. We experience so many different intersecting inequalities, and it often isn't just you're young and black, you're young and poor, you're young and disabled. It's more than one of those things. Mm-hmm. So understanding that young people are more than just young. And yeah, I'll stop it there because I could go on for hours and hours and hours.
You know, I think that is a fantastic way to end the panel. You put it so beautifully, and I'm sorry that I know others did want to ask some questions, but we are pushed for time. I just want to take this opportunity to thank the panelists again. I think that's been a fantastic discussion, so thank you so much. So just as we come to near the end of the session and this day, I just wanted to introduce something called Zero HIV Stigma Day. I will. There we go. So it's really interesting because I think Rebecca it's as if she knew that we were going to be talking about this because she highlighted really specifically that it's about not just thinking about World AIDS Day, but thinking about it continually and having another opportunity to really raise awareness about HIV and the needs of those living with and affected by HIV. But I wanted to highlight this work that's a collaboration that has been put together by NAS, IAPAC, Global HIV Collaborative, and Fast Track Cities. So this is Zero HIV Stigma Day, which is due to be launched on 21st of July 2023. And there's the hashtag for you all. Essentially, it's really mobilizing a day of action and acknowledging that there are many days about stigma and discrimination. And we endorse and we work with those days and raise awareness, but we felt it was really important to have a day dedicated to HIV stigma. And the issue about these days is that they evolve. And I think one of the first things is coming together to have the day and then working in the future to think about what will we do in the future. But essentially, it's about igniting an annual day of bold and intentional activities. And this can be in many different forms globally, but the aim is to highlight the impact of HIV stigma, highlight the intersections of stigma and shame and discrimination that we've talked about so much today, reinvigorate or initiate action to mitigate the impact, and inform people for what they can do to combat stigma. Because what is really clear, and that we've said today, is that everyone has a part to play. But how do we galvanize people outside of these rooms, outside of these echo chambers, the policymakers, the GPs we mentioned, other people in healthcare, other people in commercial settings? How do we bring everyone together to say this is not just our problem within the sector, it is for all of us to make change? And I just want to, I think I skipped over, I lost a slide there, and I think this is really important to me. So when this day was proposed, it was really it was inspired by many activists, some in the room today, but and many globally. But one particularly is Prudence Mabele, who was the first Black South African woman who publicly shared her HIV status, and it had profound impact to those living with and affected by HIV in South Africa and beyond. And 21st of July marks her birthday, we've lost Prudence, but we felt that this is a day really to honor her as well. So I just wanted to raise awareness about this for you. We're going to be sharing information about it, but Zero HIV Stigma Day, 21st of July, 2023.